Okay, so this is the second part of the musculoskeletal conditions, and we're going to look at arthrogryposis, or AMC, and sort of the other related conditions associated with that, such as clubfoot, club hand, um, and go from there. Arthrogryposis, or arthrogryposis multiplex congenita, which is where the AMC comes in, is non-progressive, and again, it's characterized by multiple joint contractures that are found throughout the entire body, right? And this is right at birth. They're seeing these. They don't know exact causes, but they're thinking that it's related to decreased fetal movements, which could be related to muscle or connective tissue disorders. It could be an inability to move because maybe there's a really short umbilical cord, or maybe there's multiple children, several children in utero at one time. They're saying there could be a link from maternal infections, drug abuse, or particular trauma during pregnancy may also contribute to this decreased fetal movement, which could increase the likelihood of arthrogryposis. Because that baby is not moving as much, it basically forms extra connective tissue. Okay, so basically what's happening is, if you don't use your range of motion, you lose your range of motion, right? If you don't use it, you lose it. And so if you're not moving during that development, your body may cause or may grow extra connective tissue, right? So extra ligaments or scar, kind of like scar tissue, which is going to decrease the movement of that joint and fixate it or contract it to that particular area. This actually occurs in 1 in 3,000 births, and so you'll see that this is quite common. I don't recall anybody having the condition of arthrogryposis, but when I think back to the clients that I've had, I certainly had clients who have had like the club foot and the club hand all at one time, and so it's kind of interesting that they weren't diagnosed with arthrogryposis per se, but they've certainly had the symptoms. Males and females are equally affected. Again, the lifespan depends on how severe the disease is, and so if you're looking at the spine and it's contracted sort of in a flex sort of position, or kyphotic or lordosis, that's going to affect that central nervous system or the spinal cord, right? It could also have less room for the pulmonary system. So their breathing is going to be affected, which of course is going to result in a shorter lifespan. Arthrogryposis can be detected with an ultrasound in utero. Okay, so they'll see if that baby is moving around, or they'll see how that baby's joints are. They may even be able to see some of that extra connective tissue with that ultrasound. So once that baby's born, OT can come into play by doing some serial casting, maybe doing some splinting, those sorts of things. Completing active range of motion, passive range of motion, and now just to kind of put my 2 cents in here, in order to make active range of motion and passive range of motion a skilled therapy, we would hope that there would be some sort of functional movement associated with that, right? Or a functional reason why we're doing passive range of motion and stretching. That's not a particular intervention that we could do for a long period of time without some sort of functional link to that, right? So we wouldn't do passive range of motion, passive range of motion, passive range of motion. Okay, you're coming to my clinic for passive range of motion every day for the next 6 months. No, we would want to educate the caregivers on doing passive range of motion, because in order to fix that joint, or in order to stretch that connective tissue, we need long, slow, progressive stretching throughout the day, and not just what we can do in maybe our therapy setting. Okay, so there is a significant importance to active range of motion and passive range of motion, but some of that is not considered skilled unless it's tied to, you know, active range or will increase active range of motion so they can catch a balloon at midline, or so that they can clap their hands at midline, so they can hold a bottle at midline. So you need those functional things in there as well. Surgical intervention may also be required. So the surgeon may have to go in and sort of cut that extra scar tissue or connective tissue, and sort of move and manipulate those bones, so that they can access that passive range of motion. In which case, then the therapist in OT treatment may be doing passive range of motion and educating caregivers on doing passive range of motion so that scar tissue doesn't form and then they're contracted again. So again, this can be a very complex type of thing. That's what we're seeing right here. We're seeing bilateral clubfoot, which is a contracture for this particular kiddo. And since he has multiple all at once, that's why he has a diagnosis of arthrogryposis. But again, with congenital clubfoot, they may not have arthrogryposis. Ironically, it's more common in boys, or it's more common in siblings that have had the condition. It can affect one foot, or it can affect both feet. And the cause, they say, is unknown, but they're speculating that it's caused by in utero crowding. So if somebody just biologically has a smaller uterus, or if there's multiples that the person is pregnant with, they're saying there's higher incidences of clubfoot with those particular cases. I also read a couple articles that talked about the incidence of the fetus's foot actually getting stuck in the mother's ribs, and they couldn't free their foot from those ribs, which again caused that lack of movement in the ankle and in the foot, and ultimately caused congenital clubfoot. And so again, that's something that can be contributed to. When we look at what clubfoot looks like, and again, you can kind of go back and look at that picture of that baby with arthrogryposis. But the forefoot is actually adducted and it's supinated. Okay, the heel is in a varus type of position. That's when the heel is turned inward, and there's equinus of the ankle, which means that there's an upward bending of that ankle, and the movement is very limited. You also see that medial deviation or supination of that foot. Again, you may have malformed bones that are causing this, or maybe just an underdeveloped bone that's causing this. On very, very, very rare occasions, there may be nerve damage associated with this, and there may be paralysis, and even a sort of a permanent deformity as well. You'll see also that if those bones are malformed or underdeveloped, you may have issues with the musculature around those bones also. Okay, so when you look at a picture with the supination, the forefoot adduction, and the equinus of the ankle, you can kind of see where there may be some short tissue, or the muscles are in like a shortened position, where on the opposite side they're in a stretched or elongated position. And so you have that imbalance of your soft tissue surrounding those joints. So to kind of go off that, here's a picture of clubfoot, and so you would see that this side, the tendons and the ligaments are really stretched because they have to go over all this area. Where on this side, they're very, very shortened. They're kind of flexed, if you would say. And so again, these muscles here are going to be very, very, very tight, or feel very tight, the longer this child's in this position, and these are going to be so stretched out they're going to be hard to sort of get back into a typical position. So medical management and OT management. You can do things such as taping, kinesio taping again, or even just sort of athletic taping to try and get that foot, that ankle back into alignment again to correct that soft tissue. You may be looking at certain types of lower extremity splints or AFOs, those sorts of things. Serial casting is another intervention. Sometimes OTs are trained in this as well to do the serial casting, which they would cast that foot in sort of more of a neutral position, and they may have to slowly progress that. In some of the severe cases, they may do an orthopedic type of surgery where they're going in and they're sort of shortening the elongated soft tissue and pulling and elongating um, the short tissue. And so they may be moving bones or removing bones or fracturing bones and putting pins in place and those sorts of things to sort of hold those bones into a particular place. In my experience, I've seen a lot of orthopedic surgeries that happen with clubfoot, and then they're immediately followed with casting. And so I've seen a combination of both. The prognosis is very, very, very good when it's treated early. Okay, so but the longer that it goes without surgery or surgical intervention or casting or splinting, the greater likelihood there's going to be with permanent soft tissue damage and contractures and those sorts of things. Here's a YouTube video on actually how they cast for clubfoot and sort of how they progress. It's very interesting. Again, some OTs are trained in serial casting, so if you decide to go that route, you may be doing that as part of your OT treatment. I personally didn't do I didn't do any serial casting with kiddos with clubfoot, but what we did work on is just basically developmentally what's being affected. So sometimes, physical therapy would be involved, and they'd be working on ambulation, those sorts of things, scar tissue management, those kinds of things, which I guess OT could do as well. If you're doing maybe gross motor types of activities to increase play tasks, you may be looking at different types of positioning. Are they in a stroller? Are they in a car seat? And if they have these casts, are there going to be pressure areas sort of on their coccyx? Those sorts of things. And so you may be doing some positioning types of things with them, educating clients on positioning, those sorts of things. Also looking at activities of daily living. Okay, so can they don and doff their shoes if they're casted? Or if they have clubfoot, can they get their pants on enough? Can they do safe transfers to and from the toilet? Those sorts of things is kind of what we focused on in OT treatment. Again, to give you more specifics on kind of when they do casting or when they have orthopedic surgery, this is typically done in that first week of life. Again, if they're done later, those ligaments may permanently be damaged. There may be permanent contractures. If they do plaster casts or serial casting, those kinds of things, they usually leave them, or they usually are on for about 2 to 3 months, and they are progressively changed approximately weekly. So it's kind of a commitment to have that done. Looking at casting for clubfoot. Here we kind of see, that ankles in position. They sort of have them facing outward. They're sort of brought in to have the hips into alignment as well. And again, they're left on for approximately 2 to 3 weeks. They're changed weekly to sort of progress that. I had a cousin who had a baby recently who was born with bilateral clubfoot. They thought it was because of a small uterus. It was her first pregnancy. She's a very tiny, tiny lady. And so they did surgery and casting again shortly after that baby was born. And he started walking, very typical gross motor, running around. He just had a birthday not too long ago, and they bought him cowboy boots, and he was running around in his cowboy boots. It was quite cute. And so again, that prognosis is really, really good here. And again, here's a picture after casting. So again, very functional, looks very typical and normal, other than it looks like his belly button is sort of protruding, but that's not associated with clubfoot. Congenital hand is something that can occur also. However, it is far less common as clubfoot. I didn't find any specific even incidences of it, but it's characterized by a partial or full absence of a radius. So it kind of goes back to, the limb abnormalities. But if it's not absent or partially absent, there may just be a bowing of that ulnar shaft. Okay, so it may be related to something orthopedic. It also, you just may have some underdeveloped radial muscles, nerves, and arteries. And so, again, that thumb may be very immature, very weak, those sorts of things. Often, the hand remains very functional. So they still can use their hand. You just may see, if there's bowing of that ulna, you may just see some radial deviation of that hand. If they have a very weak thumb, those sorts of things, there may be strengthening things that you can do. I guess this is jumping to OT treatment already. There may be some active range of motion, passive range of motion. Again, focus on function with your treatment goals. You can always educate passive range of motion, active range of motion. I worked with a little guy who had club hand, and we did some nice Bennett hand splints, which are a soft hand splint, so that he would have thumb opposition because he had very weak thumb. He could not even extend his thumb. So by having a soft splint with thumb opposition, we were able to increase some of that functional use of his hand. You may be doing some training or adapting things at school, like with writing, using a different writing utensil, those sorts of things. This particular child I worked with, I believe it was his right hand that had club hand. He just was automatically left hand dominant as he grew, but we're still using that affected hand for those bilateral hand skills, such as lining up buttons and buttoning, zipping, using eating utensils, cutting with a scissors, those sorts of things. And so our interventions really focus on all of those types of things. They may do surgical intervention too. Maybe there's some things that they can do with the ulna. Maybe there's some things that they can do with the musculature as well. Again, they're saying it's more for cosmetic benefit and less for more functional types of benefits. So something that's just kind of interesting, I guess. So that concludes sort of a look at arthrogryposis, which you all are pretty much experts in that already, but kind of a closer look at clubfoot, club hand, and some specific activities, interventions, or OT perspective that we may take a look at this with. Thank you.